Welcome back to the Incubator podcast. We're live at the NEC Symposium. We are joined with Dr. Aloka Patel. Dr. Patel, thank you. Aloka, we have to go on a first name basis. So Aloka, welcome to the show.
Thank you so much for having me.
Daphna, do you want to start us off with the first question?
Well, I guess we'll let you tell us what the main points of your talk today. You're going to tell us a little bit about disparities in breastfeeding in the NICU.
Yes. And this is an area that's really, I feel very passionately about. I don't think I really knew anything about breast milk when I was a trainee, and I realized once I became an attendant how vital it is for our infants. And only through watching what women do you realize that there's such a big disparity. And early in my career, what I felt was like people would just make assessments or kind of, not assessments, make assumptions that, oh, if she were a good mother, she would provide milk. She's not caring. And you start to think about it and you're like, what mother would try not to do the best thing, or what parent it could be for their child? And so we started to look into what were some of the reasons for the disparities. And there are many of the things that we all know affect so many elements of our life that they're outside of medicine, are really related to our social situation in this country, or maybe in many countries. So I think that's what I really want to impress upon people is people may not provide breast milk because they don't even know about it. They've never seen anyone do it, or it's too hard to do.
That's right.
Absolutely.
So if somebody is not going to be have the privilege of being here at your talk, can you give us an overview of some of the main points you are trying to make during your talk, and some of the takeaways that you would summarize for your presentation?
I would summarize just that there are still huge racial disparities within NICU breast milk provision. And there are small things that we can do as a group, and some of them are harder than others. One is really having consistent messaging, and that's something we're struggling in our own unit of. We think we're doing a great job, but is the L&D nurse saying the same thing? And I've gotten into conflict with the L&D nurse where their priority is the mother's really tired. She's on MAG, something's going on. Why would I make her pump? And I'm talking to them saying, this is a medicine for our patients. We really need it. I want you to understand that this is really vital to her health. So consistency, and then actually practical support. So you can tell somebody, please do it. Oh, you didn't get time? Okay, fine. But unless somebody is there to provide the resources, and we're doing a trial right now that's trying to help provide resources and see if that makes a difference. And then having that support. I benefited from being in an institution that Dr. Meyer was my mentor, where she set up peer counselors. I think having people who've gone through the same experience talk to you about pumping and lactation is really. So I would say finding the right personnel to support the families, making sure there's consistent messaging. I'm assuming in all of our units, there's one naysayer or a couple like, oh, it's okay, don't worry about it. Really trying to impress upon everybody, you're doing this as a group.
Can I ask you to just get closer to your mic?
Yes.
Yeah, perfect. Sorry, go ahead.
I really love this concept of milk is medicine. And I want to hear about some of the interventions you're going to talk to. And I wonder how big of a role does just education of our staff have to do with balancing some of the disparities? Like you said, I think some of the staff doesn't even understand the importance of why we need milk, especially in the NICU population.
I think it's tremendous. And we unfortunately are seeing the gaps in what happens. So when I've been at the same institution for 20 years. So it was just the culture. Everybody, when you came in as a new faculty member, you were equally ingrained, every nurse. Over the past 20 years, as people like shifted and moved, especially over the pandemic, where probably 40% of our nursing staff is new, right? There's been so much turnover in all these institutions. We're seeing that lack of education has direct transfer to what's happening at the bedside. And so we are making sure from like a nursing point of view that it's in every year and maybe multiple times a year, re-hitting it as to why it's so vital for the nursing staff to know. And then going to the OB side for that postpartum labor delivery area to make sure they understand. So I think with engagement, I feel like the model out of Orange County, that was a paper that was published a few years ago, it's a QI one, It was fantastic as they showed, as they went through each of the steps, their rates of early discharge just skyrocketed.
So it can be done.
It can be done. I wish we were doing it, but we're not there. We're still struggling. And I think each unit is going to be unique as to where you find what we need to all attention.
Do you think that this has to do with the fact that we mistakenly think that provision of breast milk is easy because it's natural, it's like you don't need anything, when in truth it requires extensive support, extensive logistics, and that often gets missed by the team of providers and nurses, because we don't realize how much work it is on these mothers to actually consistently provide breast milk to an infant that is not in their home with them.
Yeah, I couldn't say it better myself. I mean, it's absolutely true. And that's what our line of research has really been trying to look into is what does it take? And one of my slides is saying that breast milk is not free.
And I think slide. Totally right.
And I have said that in a meeting with our IDPH director where it's just like, oh, breast. And I said, no, it's not free.
Mm-hmm.
It's not free because we get it for free because the mother or the parent brings it. But they've done all the work. And I think especially when you're separated from your child, we've kind of quantified all the steps that it takes and what's the monetary value. There's some great literature kind of looking at, like, if you look at the gross domestic product, how it's measured, breast milk is not included. Right? It's a product that's not measured.
Wow.
So it's beyond us in the NICU. It's really globally.
That's fascinating. Yeah, I mean, we've had mothers who come on the show and walk you through the day-to-day of like, hey, I have to put in an alarm because there's not going to be a baby that's going to cry to remind me that I need to feed. And so I have to go on a schedule and go by myself in the living room and pump for my baby in the NICU. And it's amazing, but it's awful what these mothers have to go through to actually provide breast milk. So I'm very happy that you're touching up on that.
When we actually looked at that and we quantified it, we counted how many minutes. It's about 2 hours of work a day to pump, clean, store, do the milk.
Yeah.
And then not including the transportation of actually bringing it to the unit. So it is a lot of work if you think for a 60-day stay.
Yeah, and that's it.
And that's just in the NICU,
right.
Not beyond.
Right. And I mean, as someone who breastfed, I mean, it feels like way more work than 2 hours a day.
It does.
Yeah.
It does.
And there's this other component that I think is so hard to measure, right? The emotional toll, the physical toll, the guilt with not being able to produce enough. Yeah, there's just such a cost, as you say. So tell us about some of the interventions that you guys are studying.
So we are doing a randomized controlled trial that we're really excited about. And it's basically built on previous observational prospective studies. And we found in Chicago, at least, some of the barriers in terms of between Black and white mothers providing breast milk, some of the mediators, one of them was socioeconomic status. How many times you pump a day, your age. But we decided, you can't do anything about some of those things. The socioeconomic status, I can't fix it. I mean, one of the biggest issues in our country is lack of paid leave. But even paid leave wouldn't address all of the women who may be in a low income status, that don't have a job where they would have gotten even your gig workers. So we designed an intervention to look at exactly what is the cost and the time commitment of providing milk and try to offset it. So in our institution, there's a hospital grade breast milk pump that's provided for free at the baby's room. But to take one home, you have to rent it. It's on a sliding scale based on your economic status. So our intervention is to provide a breast pump to take home for free. It's actually a smart pump that will measure when they're pumping, when they're not. So we can get an idea of exact times with knowing that they're actually pumping. We have a milk courier that has a freezer and a refrigerator in the car that goes to the home, picks up the milk, and brings it to the NICU if desired. And then the third is we're paying women with the time they spend pumping because their time is not properly valued. So they get minimum wage for 2 hours a day, every day they pump. And that's where the smart pump is not so good because they may have verification that they pumped. And so that trial is at halfway through, and we're randomizing based on blocks of gestational age, race, and ethnicity. We're hoping that it helps move the needle. It's only still a drop in the bucket. I think it's not going to be the solution to everything, but hopefully it helps offset the work that women do that's under our list.
Yeah, and when you think about total healthcare costs, if we can do this type of work and pay people for the milk that they make, but we save so much money on livestock end, right? By not having a neck diagnosis or not having a prolonged length of stay, short admissions. I mean, it makes sense that there is actually cost savings. I can see how it would be a tough sell for organizations, but I think there are costs. Hopefully you'll show us that there are
Yes,
costs.
and I am really thrilled that the co-PI would be is Dr. Tricia Johnson. She's going to be coming here shortly today, and she's a health economist. So she and I worked together for many years, and so there will be a very detailed economic analysis in this trial to look at what is the cost of optimization. And you're right, you can't really sell it unless you can show where you save money based on all of those things, all the morbidities and length of stay. Go from there.
I think Jen Cambasser mentioned this at the end of her talk, but I wanted to maybe give you the opportunity of sharing your why for NEC and what made you want to be here today for the next symposium.
For me, it was a patient when I was a fellow, and we had a baby who had a congenital heart lesion that I was, the fellow in service, and turned baby doing well. And within my call, within 12 hours, that baby died of neck. And I remember I was so devastated. I couldn't leave after that happened. And I just realized, like, what is this disease and why is there so little we can do? And so I really wanted to be a neck researcher when I was younger, and I ended up falling into human milk, which is nice because it really is so related.
I have chills, right? Because we all have those cases that just stick with us forever. And for some of us, like you, it's really changed the trajectory of your career. So like,
I didn't realize until she asked the question that baby is always with me. Right? Like it's always in your mind or the back of your mind. And I think that's what puppy dog is about.
There's something about babies who pass away of neck in the NICU that you feel like they've slipped away from you, right? You feel like you never really had a chance to sit yourself down, cognitively think about the patient, come up with an intervention. They just slip through your finger and you're like, and then you try to catch them and they're gone.
Right. And it's exactly like Jay said, it's a thief of mind. I mean, you just, all of a sudden it's too late.
Yeah, absolutely. Well, Aloka, thank you so much for coming to the mic and sharing highlights of your talk. And we will follow you around the conference this next few days. And please feel free to come back if you have anything else to share with us.
Thank you so much for inviting me. I had a great time discussing what I'd like to talk about.
Awesome. Thank you.
Thank you.
that was great.
I hope that was okay.
Yeah, that was fantastic. That was fantastic. You're good. Don't worry about it.
Oh, it was so fun.
Yeah. Is there anything else you wanted to say? Or?
I wanted to say one thing, but I didn't say is what I'm really passionate about and I'm not talking about.
Hold on. Let's go right back.
It's a tiny little project we're working
Go.
Oh, okay.
So in usual Incubator fashion, we were just chatting off air, asking if we were able to get around to everything that Aloka wanted to bring up. And there's one more thing, as Steve Jobs would say.
Well, this is just a passion project of mine. It's very tiny, but I think part of the whole thing about breast milk is we're too late to the game, right? You can't change somebody who's in the crisis mode. I mean, you can try, but the real goal is we should be talking about breast milk long before the baby's with us, long before I think the pregnancy. So we're doing a small pilot project based off of work I did with a resident many years ago who's now a neonatologist. And now one of our junior faculty is we're going to Chicago public schools. And for fifth graders, we're talking about breast milk in a view of science and from mammals. That's been one of my passions. I think we need to take the breast away from sex. We need to make breast milk normal. And talking about it from the lens of cute animals and explaining it to children, maybe we can change the generation.
I love that. There was this push, right? The La Leche League's really about bringing it to community awareness about how important breastfeeding is. And that's kind of fallen away. And maybe that's because we're spending more time on Netflix and streaming, and there's no public advertising. Public radio has really fallen short, but I think that's a wonderful initiative, and I find that children totally get it. It's there's some threshold when we get too old where we get these, preconceived notions about breastfeeding. How is the project going? How is the reception?
Yeah, it's been fantastic. And I think when I first was thinking about it, it's like, it needs to be everybody. And so the boys are just as engaged as the girls. They're curious. And I'm just trying to break down any, that preconceived notion that they develop into their young childhood, teenage years. So I'm excited about it. We'll see where it goes.
Yeah, I think when are they ever going to hear about this? If not during these sessions, because this is not a topic that comes up at the dinner table frequently. And unless for many of these children, there is not a small child in the home that can put them in the context of figuring out that breast milk is something that matters. So I think this is a phenomenal idea. Congratulations.
And one more thing, that when we did the pilot, like the parents actually wrote us nice notes saying thanks for talking about it. And we didn't ask for input. So that made me feel good.
That's incredible.
Awesome.
I mean, I totally dig the intervention. Well, one of the things I think is just impressive is the fact that, you're taking your time to go and do this, advocacy work. And I wonder, what do you feel is the responsibility of the neonatologist to be reaching out to the community in this way?
That's a good question. I don't think it's something we're paid for, right? Obviously, it's not going into the promotion packet probably. But I think if it's something that you see a way to maybe move the needle and you can find that bit of support somewhere in your institution, just go for it. Even if it's 2 years, you try it. You just don't know what downstream effect will be, and maybe someone else will take it over. Maybe the science teacher will take it up. That's the ultimate goal. It doesn't need to be the neo or the physician. I like that.
That's awesome. Aloka, thank you so much.
Thank you.
Talk to you later.
Thanks for letting me.
No, of course.
Makes me really happy that we are starting that.
Yeah.
That's amazing. All right. Thank you
Thank you.
so much. Thank you.
Yeah, we can't wait to see what comes of it all.
Hydrate.
Yes, thank you.
Thanks again. Are we live?
Yeah, we're definitely live. That was great. That was phenomenal.